We're going to go over how to do clamping and ligating using an LMUterus model. The model that you've been given looks like this one, but we're going to start the first few steps with this model so that you can see the reproductive tract that's clipped inside of it. So this here represents where you would have made an incision into the abdomen or a coleotomy. And you'll see that this represents the reproductive tract. You'll see a Y-shaped uterus, so 2 uterine horns and a uterine body. And then you'll see some knots. So there's a knot here. This knot represents the ovary. So the section in this portion is the ovarian pedicle. That's true on this side too. So an ovarian pedicle. Then the Y-shaped uterine horns, uterine body. And then there's a knot here that represents the cervix. So these help to give us the landmarks that we're going to use while we're doing our clamping and ligating. Obviously the reproductive tract in the live patient has a broad ligament attached to the side of it, so there's a little bit more, but this is what we have represented in this model. The little black strings are suspensory ligaments, so I'm going to show you how to break those to improve the exteriorization as you're working through the model. So I have a number of clamps here. I have curved clamps and straight clamps. I'm going to select a mosquito hemostat as my first clamp. If I am working with an assistant, I generally speaking will place the rings of the clamps towards them. If I'm working by myself, I'll generally place them towards myself. So I reach in and I'm going to grab the proper ligament, and so that's potentially you cross clamp where the ovary and the uterine horn meet, and that gives you that connective tissue. And this more or less gives me a handle. So now I'm going to palm that mosquito and I'm going to run my finger down that until I find the suspensory ligament. And this one is in there pretty deep. But once I find that suspensory ligament, I'm more or less just going to apply pressure across it until it either stretches or breaks. And at that point, now you'll see I have better exteriorization for me to go ahead and do my clamping and ligating. I'm going to break this second one too, just so that I can show you what that would look like before I switch to the other model. So I'm going to clamp across the proper ligament, which is just between the ovary and the uterine horn. I'm going to palm that clamp. I'm going to walk my finger down the clamp onto the pedicle and onto that suspensory ligament, and I'm going to break that suspensory ligament. And then I'll have better exteriorization to go ahead and to do the clamping and ligating. In dogs, you have to break the suspensory ligament in almost all cases in order to get exteriorization of the ovary. In cats, some surgeons will break them and some will not, but you do get improved visualization if you have broken them. So we've switched over to the regular LMUterus model with the same reproductive tract clipped inside of it. I'm going to have you reach in and withdraw the reproductive tract. And again, you'll see the same familiar Y shape. And so this is with the suspensory ligaments already broken. So at this point, I'm going to use a modified 3-clamp technique. And so as I use 3 clamps, I can use any combination of straight or curved clamps. And I'm going to demonstrate placing the clamps towards my assistant, even though I don't actually have one right now. So what I will have cross-clamped that proper ligament, broken the suspensory, and so now I'm ready to put on my next 2 clamps. And those 2 clamps will go on the ovarian pedicle. And so what you'll see when you look at this is 3 clamps. 2 of them are on the ovarian pedicle, ovary is in between, and then the 3rd clamp is across the proper ligament. Because the blood supply comes up from the patient through the ovarian artery and through the ovary, then we will call that basically proximal and distal related to where that blood supply comes from. So I'll refer to this first clamp as the proximal clamp, the middle clamp, and the distal clamp. It's also okay to refer to them as the cranial clamp, middle clamp, and caudal clamp, although I prefer the proximal and distal nomenclature instead. So now if I had an assistant, they would hold those clamps, but in this case I'm just kind of going to stack those up. And so I have a bit of suture here. What I'm using today is PGA, which doesn't actually say on here. PGA, and the brand name of that is Vicryl. It's a multi-filament, it's absorbable. It does have a slippery coating on it that in our models can be a little bit slippery, so we'll see that it doesn't handle quite as well as it does in live tissue. What I'm going to do is go ahead and take one gentle loop down and up in my non-dominant hand. I am right-handed, so I'm going to be using my needle drivers in my right hand as I go through and do my suturing. If you have a very long piece of suture, you can do 2 loops, but we want to avoid kind of wrapping it up into a whole lot of loops in your palm. That tends to turn it into knots. So I'm going to reach my needle drivers through around the ovarian pedicle and grasp my suture end and bring it through. And then I can go ahead and, well, actually our first one is a hand tie. So I'm going to go ahead and do a hand tie. So I've passed this suture around, and I'm going to start on my index finger throw because I passed the suture towards myself. And I'm going to rotate through a second time, and that gives me a surgeon's throw. Because of the slippery coating I mentioned is on PGA, in the models you will either have to do a surgeon's or a miller's in order to get it adequately tight. Square throws alone will not get it adequately tight. So this gets pulled down, this first one, into the crush, or that area of smashed tissue created by the proximal clamp. So I'm going to go ahead and pull that down into that clamp, pull it nice and snug, and then I'm going to lay on just square throws for a total of 4 throws. If I had an assistant, I could ask my assistant to cut the suture, but today I don't, so I'll be cutting my own suture using suture scissors, and I'm going to cut those tags at 2 to 3 millimeters in length. Because we always want to be sure, most times veterinarians will tie 2 ligatures on each pedicle. So this time I'm going to switch over to my needle drivers. I did the first one as a hand tie just because I want to make sure that all the students still remember how to do their hand ties. But after that you can switch to your drivers. And so at this point I'm going to choose to do a second surgeon's throw. And slide this throw in between the first knot and the middle clamp. When I do that, I'm tying quite close to the middle clamp. When I tie close to a clamp, such as in this case with the middle clamp, I need to open or flash the clamp when I pull the suture tight. Generally speaking, I'll ask my assistant to do that. I'll pull the suture tight, I'll tell them okay or close the clamp, they'll relock the clamp, and then I'll tie the rest of my knot. If you're by yourself, then you do and handle that the same way that I did. So now I have 2 tight ligatures on this pedicle, and that means I'm ready to cut. And I have 2 ways that I can cut the pedicle. I can either use scissors, and tissue scissors are what to use. So these, for example, are Mayo scissors, so I could choose to use Mayos, or I could choose to use a scalpel blade. If I'm going to choose to use either one, what I want to be certain is that I don't leave any ovary in the patient. That would leave me with an ovarian remnant, which I don't want. So I'm going to have to cut along this curved clamp so that I remove the entire ovary. I'll demonstrate this one with scissors. So I'm going to reach in with my curved scissors and cut close to that clamp, make sure I get all that ovary out. And then as you'll see, I still have this clamp on the pedicle, so that allows me to check the pedicle for bleeding. So I'm going to come in and I can either grasp the tissue on top of this clamp. If there's not enough tissue there, I can reach under, but preferentially on the top works better. And I'm going to check and see if it's bleeding. If it's not bleeding, which in this case it's not going to, I'm going to go ahead and put it back in the body gently. And I'm going to move on to my second pedicle. And so at this point, I'm going to take that first clamp and I'm going to follow the uterine body, or the uterine horn down to the uterine body. I'm going to follow it up the other uterine horn. At this point, I would place a mosquito clamp across the proper ligament. I would palm that, slide my finger down, break the proper ligament, or sorry, break the suspensory ligament, and then I would place my other 2 clamps. So these 2 clamps, like on the previous pedicle, it's a modified 3-clamp technique, which means that the clamps are being placed, 2 of them on the ovarian pedicle, and then there's the ovary, and a 3rd clamp is placed distal to the ovary. You can see in this case I've chosen to use all curved clamps. If you use curved clamps, you want the curvature to face away from the patient, so it's cupped away from the patient. And the reason is because if you clamp down, then the clamps like to tuck back into the abdomen. If you clamp them curved up, they tend to stay retracted and stay visible quite well for you. If you use a mix of curved and straight clamps, if I had chosen to do that, then generally speaking, it's better to put the straight clamps proximally and the curved clamps distally. You can see if I replaced that, it wouldn't make a problem. However, if you put a straight clamp right next to a curved clamp and you put the straight one distal, then the two tend to interfere and it's hard to work in between them. For the sake of time, I'm just going to demonstrate one ligature on this second pedicle. You would use your judgment in terms of whether you would create one or two in your live patient. Come around, create that X, come up the center, reach through and grab that end, and then all of this, just like last time, is going to go in the crush of that proximal or first clamp. So I'm going to remove that clamp or ask my assistant to do so, and then I'm going to pull tight in the crush. And then I'm going to go ahead and finish out with square throws. And cut my tags. In a live patient, I would choose to place a second ligature, but for the sake of time, I'm going to skip that one. If I placed a second ligature, I would need to demonstrate flashing of the middle clamp when I was tightening the second ligature. And then when it's time to cut, you can go ahead, and if you want to cut with your blade, the only thing you want to be careful is that you cut away from your patient and away from your own hand. So don't cut down towards the patient. If you slip, you'll cut the patient. Don't cut towards your hand, because if you slip, you'll cut your own hand. But instead, come back behind the pedicle and cut sort of up and towards your body. But since I don't have a blade, we're going to revert back to scissors. So now I'm going to take pedicles and I'm going to flip everything caudally so that Y-shaped reproductive tract is laid out over the patient. And now I'm going to go ahead and check this pedicle for bleeding too. I'm going to grasp with the thumb forceps, release the clamp, check for bleeding, and finding none, I'm going to go ahead and tuck it back in. Okay. And so at this point, I'm going to exteriorize until I find the cervix, and I'm going to do a 3-clamp technique here. Carmelts, my Rochester carmelts on the uterine body. The uterine body tissue tends to be thicker than the ovarian pedicles, and that's why I'm using the larger clamps. If you have an assistant, you're going to want to place the rings towards them, and you'll notice that the curvature of the clamp is cupping away from the patient. That's going to help with retraction. So I'm going to place the first clamp within 5 millimeters of the cervix. The clamps that I placed on the ovarian pedicles were no more than 5 millimeters apart, and I'm going to follow the same here. So I'm going to place these 3 clamps all within about 5 millimeters of the previous one, and that will help me to place my ligatures. So I'm going to do a surgeon's ligature for my first one. And just like before, in terms of what these clamps are named, the blood supply here is coming from alongside the cervix and is through the uterine arteries here. That means the clamp closest to the cervix is the proximal clamp, and the middle clamp, and then the distal one is farthest up the uterine body. Alternatively, you could say that this is a caudal clamp, middle clamp, and a cranial clamp, although with the reproductive tract shifted caudally, you can see why that starts to get confusing. So I'm going to remove, or ask my assistant to remove, the proximal clamp. Ooh, wow, that was. And then as I do that, I'm going to go ahead and tighten this into the crush of that proximal clamp. And then for my second ligature, I'm going to demonstrate a transfixing ligature, and that requires that I have a needle on my suture. So far I've been using just suture without the needle. At this point I will need to either get suture that has a needle or thread this suture through a loose needle, which is actually what I'm going to do here today. And so we thread the needles from lesser curvature to greater curvature through the eye of them, this direction. And then I'm going to pull enough through that I'm not going to lose this, through the needle. Some people will wrap them through a second time. I generally don't do that. It does create a little bit more drag through the tissue. I'm going to grasp this needle 1/2 to 2/3 of the way down the curvature, and then I'm going to pass this needle through the uterine body. Generally speaking, a good way to do this is to hold the tissue upright. So if you're poking down, you don't poke into the patient. Some people will come from behind. So there's a number of correct ways to pass the needle. As long as you're not poking your patient, you're all right. I'm going to pull this needle through, and then at this point, I actually don't need this needle anymore, so I'm just going to set it aside. If it were attached to my suture, I would probably choose to keep it, but that's not what I have here at the moment. So at this point, I'm going to go ahead and tie just a square throw. And so this only goes around a small part of the uterus, or up to 1/2 of it. And then I'm going to take one of the ends and reach the end around. In my case, I have to reach the short end around because I want to tie the other 4 throws of this knot on the side opposite the first knot. So my first throw I put here, and then my next 4 throws I'm going to put on the opposite side. So that first throw that I've already laid down, because my suture wasn't going all the way around what I was tying off, that one doesn't count towards my 4 for a secure ligature. So I'm going to start over again, and I'm going to choose to do a surgeon's here again because this is PGA, it has a coating on it. And I'm going to pull that throw down nice and tight. And then, because this is a second ligature and because it's near a middle clamp, I'm going to flash that middle clamp or ask my assistant to flash that middle clamp. And then at this point, after I retighten the suture, then that middle clamp could be reclipped. And now I have 3 more throws to make a secure transfixing ligature. And then when I cut here, like before, I'm going to cut in between 2 clamps. Here there's not an ovary that I have to worry about not leaving a remnant for, so I don't have to worry about that. I can reach through, again, if I'm using my blade. I usually will hold the clamps at this point, take them from my assistant, and I reach the blade in, and I will cut towards myself, towards my body, but away from my hands, away from my patient. Or you can reach in and use Mayo scissors as well. And then reproductive tract, this can get dropped in a parts bucket. Since I don't have a parts bucket today, I'm going to set it sort of to the back of my instrument field so that I can check this ligature, for bleeding. So I've got my 2 tight ligatures on there. I'm checking I don't have any bleeding, so I'm going to gently tuck that back into the body. It's important to remember that this is not a recipe for a spay. This is a spay model, but when you go and you do surgery on actual live patients, the reproductive tract will lead you to make different decisions. Different patients are different sizes, ages, parity, how many pregnancies they've had, so you need to make those decisions based on what your knowledge of the patient is, your experience, and what you're seeing during the surgery. This is only a procedure for how to go through and do clamping and ligating on this model, not a recipe for a live animal spay.